So we now move on to the first talk of the day, and that's none other than Professor Michael Edmonds, who needs no introduction. He is one of the founding fathers of diabetic foot in the world. And to him goes the honor of starting one of the earliest diabetic foot clinics, multidisciplinary diabetic foot clinics in the world, in the King's College London. And he's a consultant diabetologist at the King's College Hospital and honorary professor of diabetic foot medicine at the King's College London. So we are honored, Mike, to have you today in the DFoot International Online Education Program. You can switch off the slides and on to you, and you can start your talk.
Thank you very much, Vijay, for your kind introduction, and greetings to everyone from London. We're here in the afternoon. Major amputation is one of the most feared complications of diabetes. And as we know, every 20 seconds in the world, someone loses their leg due to diabetes. And this is just not acceptable. And we've got to do something about it. What is the reason why so many major amputations occur in diabetes? Well, the diabetic foot is complex with an aggressive time-dependent natural history. This defeats healthcare systems because they have not understood the time dependence of the history and have not adapted to overcome it. And simply, time is tissue. Empirically, we can recognize 6 phenotypes. This is to help us understand the natural history. These scenarios are vulnerable to the rapid development of necrosis and thus the risk of amputation. In the neuropathic foot, we recognize the neuropathic ulcerated foot and the Charcot foot. And in the ischemic foot, clinically, we can recognize the neuroischemic foot with mild, moderate ischemia, the critically ischemic foot with severe ischemia, the acutely ischemic foot with sudden, overwhelming ischemia, and the renal ischemic foot. Now, each of these will have their scenarios, and they will have their stages, which can be depicted by the simple staging system. And that will go from normal, high risk, to ulcerated, or where there's tissue damage, limb threatening, either due to infection or ischemia, and necrosis. So I'd like to just present this pictorially. Some of you may have seen this before, but I think it just gives us the roadmaps of how we've got to deal with this. The neuropathic foot, initially with this prominent metatarsal head, develops an ulcer, becomes infected, and then leads to infective necrosis and the risk of amputation. More rarely, the neuropathic foot, subjected to trauma, becomes a Charcot foot, the hot red swollen foot. If not immobilized, will become deformed, ulcerated, infected, and again, infective necrosis. Now we go on to the ischemic scenarios. In the neuroischemic foot, ulceration on the margins of the foot, it will become infected and lead to infective necrosis. This is in contrast to the critically ischemic foot, where there is a severe reduction in blood supply. This leads to tissue hypoxia, ischemia, and necrosis. And this is in contrast to the acutely ischemic foot, where there is sudden overwhelming thrombosis or embolus, and that leads to a cyanotic foot, a blue foot, a mottled foot, and then a gangrenous foot. And then finally, the renal ischemic foot, which probably deserves a pathway on its own, presenting with these very specific lesions, which then seem to progress inexorably to involve most of the foot. So these are the pathways. You notice the 3 on the left are driven by infection. The 3 on the right are driven by ischemia. But whatever the process, there is a sudden deterioration in the foot. And this has colloquially been called a foot attack, to liken it to the heart attack and brain attack of stroke. But we've got to confront this chaotic situation that is happening all over the world, and it's happening as we speak here today. And we've got to basically control the situation, both in the clinic and in the hospital ward. So we've got to get wound control, infection control, vascular control, mechanical control, metabolic control, and educational control. And no one person can do this. So we need a multidisciplinary diabetic foot team, the MDFT, and that is used to treat both clinic patients, outpatients, and also ward patients. And this is the whole team, which is ready to act when there is a problem. So it's not so it's a podiatrist, nurse, orthotist, diabetologist, microbiologist, surgeon, and radiologist. So these are people on the front line, and there are various permutations of these. From day-to-day care, there is more the nuclear model. That is the podiatrist, or more rarely the nurse, supported by diabetologist, stroke surgeon, that is responsible for day-to-day care, and then we'll bring in these experts who will be ready to give their support. It won't be a case of referring somebody to their outpatients and being seen in 3-4 weeks' time. These people will be ready to act. Just to show you the timetable in our foot clinic at King's, which probably illustrates this. So we have an emergency clinic open every day to see acute urgent patients. Then on a Monday, there's the joint diabetic foot orthopedic and with plastic surgery clinic and ward round. That's the morning. It carries on into the afternoon alternately. And there's also a background ulcer clinic. On Tuesday, a joint diabetic foot vascular clinic and ward round. On Tuesday afternoon, the ulcer clinic and an MDFT meeting on the ward, involving occupational therapists and physiotherapists to take the whole holistic care of the inpatient. Then on Wednesday, a joint diabetic foot orthopedic clinic and a Charcot clinic, a vascular radiology meeting midday to look at all the angios, a Charcot clinic in the afternoon. On Thursday, again, a joint diabetic vascular clinic and ward round, and also we have a joint diabetic foot orthopedic clinic, ward round, a background ulcer clinic, and then Friday, ulcer clinics, but often you get quite a lot of emergencies on the Friday. So this team and this clinic, the main principles are focus of care. It's a physical operations center. This is where patients can work towards as a haven of care on a patient-friendly pathway, and it's the hub for the MDFT, for coordinated and integrated care. Now, our time is limited today, and we want to allow time for my co-speaker and also for a discussion. So I'm going to just mention some of the principles of this integrated care, such as rapid access to care, early diagnosis, especially of infection, casting therapy to offload the neuropathic foot, the urgent approach to the Charcot foot, and robust ultradistal revascularization, because it's the distal circulation now, the situation not only below the knee but below the ankle, that is the new frontier in treating vascular problems. So rapid access to care, open access to see emergency cases on the same day or within 24 hours. That is the way we run it. And we take referrals from all healthcare professionals, general practitioners, community nurses, community podiatrists, and referrals from patients. And this was particularly started by Ali Foster in the early 80s and has continued. And just to illustrate this, this was a brilliant diagnosis by a community nurse who was seeing a patient at home. The patient was an ischemic. The patient had noticed some discoloration of the apex of the toe. The nurse could have easily thought, well, this is some degree of ischemia, which we know about, but she noticed the discharge, the exudate, slight redness, but above all, the discoloration and the cyanosis. which may, she thought, have been related to infection. And indeed, it was infection. And within 48 hours, treating with antibiotics, the color of that foot and the oxygenation had improved. If she had not intervened, I think that toe could have become necrotic. So early diagnosis of infection, and I'm afraid there is often a delay in diagnosing infection because local and systemic signs of infection are often absent. When we looked at 50 patients hospitalized for diabetic foot infection, systemic signs were diminished. They had raised C8 reactive proteins, which is a more reliable sign, actually, but their body temperature, median body temperature was 37, was not raised, pulse of 81, respiratory rate normal, and the white blood count was also normal, and the neutrophil count normal. This is not a new observation. Jan Appelquist noted this in the 90s when he looked at people with deep-seated infection, deep foot infections, and about 50% of patients lack clinical signs of infection, which he took as a body temperature greater than 37.8, a SED rate of greater than 70, or a white count greater than 10 to the 10-9. So this is an important thing. And I think we have to have a different approach to the diabetic foot with neuropathy, because when there is no neuropathy, symptoms, and we notice the symptoms and signs, we do investigations, we get a diagnosis, we treat, and we heal. When there's no neuropathy, no symptoms and signs, no investigations, no diagnosis, no treatment, tissue death. So we've got to practice what we call, in a colloquial way, neuropathic medicine. You've got to look for the minimal symptoms and signs. You've got to use imaging and lab tests to help you, and that will get you to the diagnosis, treatment, and healing. So neuropathic medicine, high index of suspicion of infection, and coming to this also, Charcot, subtle signs of disease for infection, temperature 37.3, look at the inflammatory markers of C-reactive protein and use imaging early. People criticize C-reactive protein. You've just got to remember it's 24 hours behind the time. So you've got to assess it in that sense. So that's the first two principles: access to care, early diagnosis, casting therapy to offload the neuropathic foot. If we take the second, stage 2 and stage 3, look on the left side, the neuropathic ulcer and the Charcot foot as well, they respond extremely well to offloading. Now that's not a new statement as such, but we do use the total contact cast very much to offload the neuropathic ulcer, and secondly to immobilize the Charcot joint. When it's not possible to use a total contact cast, we will use the neuropathic. We will use an off the cast. This is an air cast, which as long as it will be taken into the foot, if the foot is deformed, that air cast is not helpful. But going to the Charcot very briefly now, we try and use the total contact cast when we've got a hot, red, swollen foot, to prevent this deformity, which I've already showed you, leading to ulcer, but also to prevent the severest deformities, which can, in fact, immobilize people completely and prevent ambulation. So I'm not going to go into the detail of the Charcot because Bob Frickberg is talking on the Charcot in a few minutes' time. Just to summarize, throughout the whole of this talk, I want to stress we've got to have an urgent approach to everything, and especially the Charcot foot. We've got to get an early diagnosis, and then we can get the total contact casting to prevent deformity. If patients present later with deformity, now surgical reconstruction is a possibility. And I would like also to stress, over the last decade, we have come to know that the chronic Charcot foot, with deformity of some duration may well be ischemic by the time they present to us, and they will need revascularization. Just to illustrate this, this is the deformed foot. The patient before assessment had a blockage of the superficial femoral, so needed a fempot bypass, then had reconstruction with nailing and plating of hindfoot and midfoot, but also needed a further revascularization post-surgery, and this was a dorsalis pedis bypass going there and going down into the dorsum. And then the patient needed multidisciplinary wound care, negative pressure, skin grafting, and then a return to plantar-grade foot. So that's the Charcot foot. The ischemic foot, the neuroischemic foot, is becoming a very common presentation to the foot clinic, and revascularization is extremely impossible. In some cases, in the neuroischemic foot, conservative treatment to heal that ulcer with podiatric care will be enough. But when one gets to critically ischemic foot, and of course acutely ischemic foot, and to a certain extent renal ischemic foot, we will have to consider revascularization. Ischemic patients are seen in a vascular one-stop clinic. Patients are treated at the earliest stage of tissue loss within 24 hours if urgent. Vascular lab and clinic assessment the same day, duplex angio to locate the arterial disease, and then a decision for angioplasty or bypass. And below the knee and below the ankle, expertise in revascularization should be available. This was a report from Hani Slim of our vascular surgical group on the distal and ultra-distal grafts, 179 distal, 51 ultra-distal bypasses, mean age 75, 65 had diabetes, 30% had chronic renal failure, 30-day mortality 1.7%, 1-year major amputation 3.4%, 1-year mortality because of the cardiovascular issues 12.2%. This is one of the figures from the paper, and you can see that the patency rate of the distal and the ultra-distal bypasses, you see here blue and red, was similar at 1 year, 87%. So these ultra-distal bypasses to the foot can be successful. And also endovascular techniques now go down into the foot. This was a patient with a necrosis at the apex of the toe. You can see the calcified metatarsal artery here. This is the angio using gadolinium as a dye because of the renal function, and you can see hardly any perfusion to the first metatarsal. The patient had a wire and then balloon put down to the dorsalis pedis and the first metatarsal artery, dilatation of the DPA and the first metatarsal artery to restore perfusion to the first ray, and that together with the podiatric care in the clinic facilitated healing. And with this combined approach, endovascular, and it's often a hybrid of as we saw with that Charcot case of it's surgery, vascular surgery, and sometimes angioplasty, you can reduce the number of amputations. So in our neuroischemic group, we had 2 out of 182. In the critically ischemic 2, none out of 4 in the acutely ischemic, and 2 out of 27 major amputations. So I'm coming now to summarize in the multidisciplinary diabetic foot team working in the multidisciplinary diabetic clinic. We can heal ulcers using plasters and of course orthotics. We can accept emergency referrals. We have vascular diabetic foot clinics, orthopedic diabetic foot clinics, an outpatient antibiotic service, debridement and minor surgery, post-operative reviews and follow-ups. All these diabetic patients who have their vascular surgery and the orthopedic surgery come through the joint clinics, and then the Charcot Foot clinics, of course, education, research, and coordination of primary and secondary care. So I think we are now working towards improved survival of the diabetic foot with abundant energy and patience and enthusiasm within a multidisciplinary diabetic foot service. Surprisingly, good results can be achieved. So I overall bring, I think, good news. Up until recently, the diabetic foot has defeated every healthcare system in the world. But now advances in our understanding have led to improvements in care, and ulcers can now be healed and amputations prevented. And I'm sure all of you logging in today and listening are doing your best, and well done for looking after the person with diabetic foot problems. Thank you very much. And back to you, Vijay.